it goes back to, does everybody on site really know what to do? It's such a hard pill to swallow that, and I don't, were you here in the morning? I don't know if
I was
not. So when my wife walked out the door, she didn't think it was life-threatening. She just thought that she was trying to keep her calm and thought that, saying, hey, we're going to the ER, everything would be fine. And a mile down the road, everything deteriorated. So we ended up at Roswell Fire Station number 1, where nobody was there. And she was on the phone with 911, and an ambulance responded in 3 minutes and 47 seconds, but it was parked behind the building. So there's a whole conversation about why is an ambulance not in plain sight, and why would it take that long to drive 25 yards? But then, when it was clearly stated on the 911 call that it was some sort of asthma attack, and it was clearly stated to the folks that responded, at the end of the day, she was provided oxygen and a ride to North Fulton. And we're left to live with, where's the disconnect? Why, again, with asthma so prevalent, why wouldn't first responders know protocol like the back of their hand? Why wouldn't it be recognized that giving oxygen, just pumping oxygen is not gonna help her? It won't be the solution. And did panic set in? We don't know. Did they not know that she needed medication? We don't know. There's plenty of things we don't know. And Brennan, we just want to know, one, were they trained? If they weren't trained, why weren't they trained? Or where's the disconnect where we didn't know that they should be trained? And 3.5 years later, have they been trained?
So when we use the word adherence, what does that mean? What it means is compliance to a medication. Whatever the medication is, we want to be sure that as asthma patients that we're adherent to that regimen that the physician has put for us to take. So that's not happening. Why it's not happening? Patients are not aware of the medication, what it does to the body, and why they're on that particular medication. So our job and our duty now is to properly explain to a patient, okay? I usually go into a metaphor of a car, okay? Everyone in here owns a vehicle, am I correct? Okay, so we all can understand that getting into a vehicle, starting and leaving, that vehicle operates every day, okay? That's all we can understand. But understand that if we go deeper, the vehicle needs oil to run, okay? So I make that correlation with the medication to our body. As asthma patients, we need oil. And we need to continually put that oil into the body. Because if we don't, that car is going to break down. It's going to stop operating. So it's the way that we convey the message of adherence to the patients. Why? are we on these medications and what they're doing to the body. If we can convey that message to the patient, child provider, parents, family members, the community, then you'll see a rise in adherence to the medications.
When you think for a pharmacist, adherence, sometimes that's not a good thing. It's particularly if you don't understand the side effects to a medication, or we're not talking about when you should change therapy or step down, or black box warnings. These are discussions that are very technical, that parents do not understand, and it is our responsibility as healthcare professionals that we connect the dots and we let them and get them to a point where they understand that these medications, if used appropriately, will support improved health outcomes. But if not used appropriately, and sometimes that could mean that the prescriber has made a mistake, the pharmacist hasn't caught the mistake, the patient receives it and is taking it and administering the medication, but no one has stopped the perfect storm, that adverse event or that bad experience with that medication, because we didn't do our due diligence in terms of the education component. So I'm a pharmacist, and Rite Aid, we are in the business of making sure patients and communities are adherent, but I don't want us to walk away from this discussion without understanding that with adherence comes a great responsibility, that we understand the parameters that these patients, we all need to be focused on as we improve control and self-management.
So the doctor may be very quick or very fast. We make a special effort in our clinics to educate. So we have an asthma educator in our clinic to show you how to use your medicine. So please don't walk out of a doctor's visit unless you know how to do that. The other element is for all of our asthmatics, we have an asthma action plan. I'm sure you're all familiar with it. Some people throw it out as they're walking out the door, but we recommend that you demand it from your doctor. And if they're not giving it to you, then they're not doing their job. So I think this is one of the key elements for we as patients need to go up to the doctor and say, I need these things because I don't know what I'm doing. You need to explain all the medicines. Am I using the inhaler properly? Are they giving you a peak flow meter in the clinic? Are you getting a spacer? Do you know how to use everything that they're telling you? Because you have to use it every day, even if you're feeling well. They need to explain to you that there are controllers that you take every day. There are things that you take during exacerbation. So all this education piece is absolutely critical. And I kind of send it out to patients that you need to ask your doctor for all of this information. Demand it from them. Don't just walk away thinking, okay, well, they told me what it is, I'll figure it out. That shouldn't be when you walk out from the clinic. And we try not to do that in our clinic. We take the extra time to make sure you get all of that. And that information. And we also try to basically help phenotype you so that if you're allergic to grasses, we tell you which app to go to when the grasses are out. And you should know that. You should ask your doctor, do you know about this site where this pollen is making me sick or this indoor allergen is making me sick? Therefore, I need to change my covers in my bed. I need to cover them up. That's a piece that's important for you. You should demand that from your doctor if your asthma is not under good control. So we do all of that phenotyping. So that part is really, really important for you to ask your doctor about these questions. And so I bring it back to the patients. If you know what to ask and you know how to use your medicines, you will feel you need to ask that from your doctor. So to go on the other element of the other aspects that we have, some things in asthma are due to your immune system they're basically making immune responses to things that you don't necessarily that you need anymore. For example, a big component of the immune response that we have now are to parasites, and we don't need them because we live in a really clean environment. But the problem with asthmatics is now they're using that immune response to develop it against things that are out in the air, like grasses and tree pollens and cats and dog dander and things like that. So this is an abnormal immune response to things that we don't really have, that we shouldn't have an immune response to. So what we need to do is we need to basically modulate some of that. And two big key elements, there's multiple phenotypes, but I won't go into all of that, but the key phenotypes are there's a special antibody that causes those allergies, that's called IgE. We have blockers to those now, and that's totally available, and you can ask your doctor about that to decrease your asthma exacerbation rates. There's other new molecules that are coming out, so there's a special cell type that we used to use to fight those parasites, but we don't need them anymore. There are these eosinophils, it's a special cell type that's in the body. We have blockers to those growth factors now. So these are really new targets, and they're way better than taking steroids every day, because people hate that if you have severe asthma.
If there's one concept, legal concept I can teach you guys today, it would be the term negligence per se. Negligence per se deals with situations where someone breaks a law and the consequences for breaching that law are assumed. What that means is, if you were a loved one, as we discussed earlier, struck by a drunk driver who imbibed 8 glasses of scotch and was in violation of the legal blood alcohol limit, and they hurt you as a result of that, you don't have to prove to the jury that their behavior in getting drunk before they got behind the wheel of a car was unreasonable. It's assumed because the law already sets a legal limit for how much you're allowed to drink. We need those same standards in terms of air quality in the state of Georgia. You just heard Dr. Lee present all the types of health consequences that can come with asthmatics, especially when they're not provided proper air quality. I don't know if you guys are aware of this, but this is not a given in court. I can literally walk into a courtroom and a landlord can admit that they haven't used proper filtration on the system. They can admit that the tenant, and this is particularly true with low-income families that don't have any other place to go or can't afford to lease one apartment while they find another one, a landlord can literally walk in and admit that he's used a low-quality air filter, or that he delayed in making repairs to high moisture content, high mold content. And it's still not a given, even with a treating doctor's report of environmental hazards leading to the child's industry. It's still not a given that the two are related, that the behavior is related to child's injury. So this panel's work is critical in establishing laws, both for testing of units to make sure that they're safe for families, especially for children with asthma, that prevention standards are set. If there is a problem, if it doesn't use a proper air filter, if there's been a water intrusion issue, what are the standards for repairing that? Is it enough if a landlord slaps on a coat of paint until it shows up again? Or do they have to hire a contractor, an engineer to fix it? We need to set these types of standards to hold people accountable and to protect children, not just children, but low-income families who are the most vulnerable ones out there. And this is gonna require a group effort from environmentalists like Richard, from Dr. Lee, meeting with politicians and lawmakers so that they understand these health consequences. Because right now, when a low-income family is placed in this situation, and my heart goes out to Tim because I have other clients that have lost children to environmental hazards, and there is no cost-effective way right now for them to get justice under Georgia standards as currently written. And so I hope that this panel can come together and start putting those standards in place to protect families and these children going forward.
You know, Dr. Lee talks about a comprehensive assessment and then critical time spent with patients around education. That's a specialty setting. Oftentimes you find that the primary setting where the person is going to be seen most often, about 7.5 minutes worth of engagement, which is nothing. So the primary doctor assumes that the pharmacist is having these discussions. There is no specialty engagement most often because, I mean, at least this is my professional opinion, and I've been a pharmacist 23 years. The primary care providers are afraid of losing their patients to specialty practice, right? So then you have this primary healthcare professional, again, my 23 years of being a pharmacist, at some point not really qualified or doesn't know when to relay that patient to escalation of specialty care. And so what ends up happening, overutilization of medication, the person is not getting better, and now we're playing with Russian roulette, right? Ticking time bomb. So what Nazira is referring to as a coalition chair and as an executive, I manage pharmacies. My job will go in to make sure our pharmacies are running based on state and federal regulations, local policies and laws, and specific to corporate mandate. And so this one day I was in a pharmacy doing a coaching session with one of my pharmacists. Pharmacist was extremely busy, and so this patient comes up, a male, 35 years of age, visibly sick. It was cold and flu season, and he presents 3 or 4 prescriptions, a steroid, cough suppressant, and a broad spectrum, very powerful antibiotic. So I look at the prescriptions, noticing that if he has a cold, now we have an overutilization of medication. It's not appropriate for care. But I then stop to take a look, assess him, see what's going on. I noticed that he was on the same regimen or protocol for about 6 weeks. So looking at it at this point, now mind you, I manage pharmacists. I'm not necessarily dispensing medication like I used to, but healthcare is healthcare, and I noticed that he's been on medication that clearly at some point some diagnostic tests should have occurred, some additional assessment, and maybe a specialist should have been involved at this point. So I asked him a question. I said, "Where do you live?" Found out he lives sub-level in a basement apartment. Poor air filtration at best. He's been experiencing these symptoms since he moved in. He's been there about 3 months. And within 6 weeks of the 3 months, he's exhibiting signs of respiratory distress of some sort. I end up recommending that he contact Air Allergen, which is Richard's company. Richard, as you can tell from his discussion, is a scientist. He's an environmental scientist. And I wanted this gentleman to have access to someone who can go in and assess his indoor air quality. Now, this is rare because most healthcare professionals don't have access to even knowing to make that kind of a recommendation. And oftentimes what we breathe, it does matter. This 35-year-old male who's never been diagnosed with asthma is clearly demonstrating signs of some sort of respiratory distress. He's losing days of work. By the way, he'd been out for 2 weeks at that point from work. Just the monetary return on the investment, had somebody made that recommendation a long time ago, he would have gotten better. He was clearly under distress. He wasn't feeling well. He was weak. Gave him that recommendation, the light bulb, like no one had ever talked to him about what he breathes matters. So I guess to summarize, Nazira, if we don't take this information and start connecting the dots, I got Dr. Lee's cards because we're going to talk after this. Start connecting the dots. You know, to have these sort of summits is just pointless. It's really about making sure that we take this information and get it out into the communities we serve.
One of the first things that I said to Nazira when she approached us about setting up the Asthma Coalition was that if we ruled the world, we could have this issue about the indoor air quality I was referring to at the time settled by the end of the summer. But the reality is we don't rule the world. And the synergies between, and the reason we don't is because there's so many different facets to this problem. And unless we have the pharmacists that look through their medications that they're getting, and they keep in mind they can get medications from different doctors, and the doctors don't necessarily know that they're getting different medications from different places. That's an example of how someone can forensically understand that there's more going on than just what can be done with the treatment. There are things that we see when we have people who are calling us and talking about health concerns, where we can refer them potentially to someone like Dr. Lee, who's talking about this new asthma issue that's happening. And in the same way with, we get a lot of calls from people who are living in rental properties. And the problem there we have is there's a disconnect between the benefit of having a good filter in your furnace, say, and the cost of doing that. If the cost goes to the landlord and the benefit goes to the tenant, there's a disconnect there. Someone like Carson can help bring that connection back together again, to help facilitate that things that are necessary to be done. And at the same time, there are certain responsibilities that the asthmatic families have and the parents have. And if it's a case where there's an intervention with the family, or there's children going to the emergency rooms and that kind of thing, the help may very well need to be involved with through a respiratory therapist, excuse me, or some of the other disciplines that are necessary. So there's not one size fits all. And one of the important things that Nazira has really taught us in this is that so many of each of us live in our own silos. If someone comes to us and we're a pharmaceutical company, we want to figure out what kind of a drug we can give to help solve that. If someone is an allergist, they want to give them allergy tests and see what they can do to try to solve that. Somebody comes to us, we want to see what we can do to their indoor environment and try to solve that. And the reality is that all of these things play a role in it. And it's our view, we don't have to solve all of these problems to get people back to reasonable health care, below the threshold where they need emergency intervention. All we need to do, as Diane so well put it this morning, is bring it below the threshold where they need that kind of emergency intervention. And some of those things can come from each of these disciplines, but working together, we can make it happen much more quickly and solve the problem for these people, so that they don't have to take medication for things that they don't have to be exposed to.